This video will begin looking at nursing assessment of the integumentary system. In reviewing this material again, we're going to talk about keeping it as possible. When we look at the slide that contains the NCLEX blueprint, you'll see that the big issue with skin is going to be either performing an assessment to identify potential or actual problems, and then just implementing measures to promote skin integrity. So we don't want to get really lost too deeply into like the varying disease processes unless it's going to be something that's pretty common from us as a nursing perspective. So we do have some physiological changes depending on where you're going to work. Obviously, we're going to look here at the differences between the newborn and the geriatric client, but anybody as it is at increased risk for wound healing, skin integrity issues, when we have issues with either hygiene, mobility, if you have incontinence, those are going to really put you at increased risk for these skin breakdown processes. And newborns and geriatrics do have in common the fact that their skin is going to be very thin. It's going to take less pressure, less options or difficulty to cause issues as far as the skin system is concerned here. So with newborns, we know that their skin is thin. They have very little subcutaneous fat. So they're going to have a difficulty regulating their body temperatures, which is why we swathe them, of course. They will also see an increased absorption of topical medications. So if we do have some sort of, urticaria, some sort of dermatitis, something like that, we don't have to put as much as we would for an adult client. But I think most of us understand that just from either having kids or being around kids. Of course, their immune system isn't fully fleshed out, so they have increased susceptibility to infections. The epidermis is fairly loose, right? They lack the ability to sweat, and there's less melanin in the skin. In our geriatric clients, we still have a loss of elasticity. They can develop benign growths, these vascular hyperplasias such as cherry angiomas, which are totally benign, but we need to be able to separate a cherry angioma from something that is abnormal. So you do have this increased risk of secondary infections, usually something like a cellulitis. Obviously, the most common one is probably the skin breakdown from positioning. And then changes related to hereditary, sun exposure, hygiene, nutrition, just their overall general health, any underlying comorbidity. We want to ask our clients about their use of any reoccurring or topical over-the-counter prescribed medications, so vitamins, hormones, antibiotics, corticosteroids. And then we want to document the use of those medications and prescriptions. We do know a lot of times that we get lost in the healthcare setting. Somebody will tell us that they're on a certain medication and that doesn't get prescribed by the caring physician. So that's something that we can address, and we can mostly address it in our care plans. And I pretty much, every client that I have, you always are going to be at an increased risk for skin integrity issues. The sun is a big one for us. I have seen, again, these types of questions on our practice questions and whatever test bank that you prefer. But we need to define what we're looking at. So it says to use a broad protection or a broad spectrum UVA and UVB sunscreen. And that seems like to be the most common question, that you want UVA and UVB, or the minimum SPF is 15. This term waterproof is misleading. You should reapply sunscreen anytime you're coming in and out of water. And again, I think that that's something that most people are fairly common knowledge. So obviously we're going to ask them about any history of chronic or unprotected exposure to UV light, right? If you do have a history of skin cancer, you should use products with an SPF of at least 30. And sunscreen should be applied 20 to 30 minutes before going outdoors, even in cloudy weather. We're going to look for photosensitizing medications. And that's anything that's going to give you basically this exaggerated erythema, right? The swelling, erythema. You can potentially end up with vesicles and papules or plaque-like lesions, depending on your use of the medication. I think probably, the colloidal silver we see in the news because it does turn your skin silver, and there is some conspiracy theories about overuse, because obviously we do use it in the healthcare setting, but the overuse of it. So just be kind of looking at some anti-infectives, antihistamines, antipsychotics, diuretics, hypoglycemic agents, and non-steroidal anti-inflammatory drugs, so your NSAIDs. So those are the most common ones, and hopefully at some point along the way we've seen a topical reaction, and we have to really figure out, is this a topical reaction or is this truly an allergic reaction? So this is the easiest way that I could find to show you what just the assessment of the integumentary system is, right? Looking at the skin, the nails, and the hair, we're making sure everything is normal, but it has to be normal for your baseline. The biggest one I would say during the normal physical assessment of the integumentary system is I see so many students going in and they're trying to do a head-to-toe assessment, yet nobody is looking underneath the gown. Nobody is actually having the client roll over on their side so we can look at the back. When we look at skin breakdown, I always get, well, I wanted to wait until later. And so the longer that you wait, the higher at risk these clients are for skin breakdown. When I first started out nursing, we saw a lot of our techs who were using, 2, 3, 4, 5 pads because they didn't want to have to go in and put a new pad underneath. But I think for every additional layer, and now I know we use chucks, but it's still an additional layer, it can be somewhere like 15 to 30 extra pounds of pressure that client is experiencing. So it's really not okay to be using all these extra layers of pad just because it saves us a little bit of time. It's actually doing a disservice to our clients. So here are our information that I could pull from the NCLEX test plans to help guide your studying when you're looking at the integumentary system. It's performing a skin assessment and implement measures to maintain skin integrity, provide skin care to clients who are incontinent. Of course, we should be washing them frequently. We should use barrier creams and ointments. Anything that's going to promote their mobility, to actually have them using a bedside commode, to DC the Foleys, all the stuff that we do every day. We want to identify complications of immobility, which we've talked about, and then a risk assessment, and that's going to be in your care plan. If you do find something abnormal, just a refresher, right? We're just going to go straight back to Sesame Street. It's A, B, C, D. Asymmetry, irregular borders. The color is going to vary, and the diameter is going to be bigger than a pencil eraser. This is the next one of normal versus melanoma type of characteristics of that kind of skin disorder. So I'm not saying that the ones on the left here, if it's large enough or if it's causing irritations, you might want to get it looked at by a dermatologist. It's just not an urgent situation. Any change in your integumentary system, you want to have assessed as soon as possible. But obviously, if you do see something on the right-hand column where you have this asymmetry, the borders irregular, the colors in this one are clearly darker on the left and lighter on the right, and then that diameter is large, you do need to urgently see a healthcare provider. We do have some common skin infections we'll address briefly. Bacterial, it's mostly impetigo and cellulitis. We're going to go ahead and look at those. You do have Staph A and Group B hemolytic streptococci. Obviously, these infections can get in there and cause damage to the integumentary system. You do have viral, you do have fungal, and usually diagnostically speaking, we're probably just going to be looking at some sort of smear to get whatever that offending agent is sent down to the lab so that we can look at it under controlled conditions. Impetigo is, I don't want to say it's fairly common, but it's more common. So this is lesions that begin as macules and develop into pustules. And these form this honey-colored exudae. It usually affects the face, the hands, the arms, and the legs. Think of like where people put their hands. It's highly contagious. I'd probably see it more in your nursing care of children section than you would from a geriatric perspective. So you want to make sure that we're not putting these people together, that, we're teaching them hand washing, and I'm probably getting ahead of myself here, that we're going to use systemic antibiotics, clean gloves to prevent the spread of infection. You can soften the crust with warm saline soaks and soap and water. And then some alcohol-based lotions and the use of petroleum jelly are not recommended. So we don't want to be using anything that's going to dry this out or prevent this from being open to air. Cellulitis is just an inflammation of the subcutaneous tissue. We talked a little bit about this with PAD. You still have this erythema with this differing borders, and this is fairly common for when I suspected somebody had cellulitis. We used to take a Sharpie and outline the borders because you wanted to know if it was spreading. So for like this one, the foot, I would have done something like this. It can promote, just general feelings of malaise, fever. You can treat it with heat. Obviously, after you get an order, you want to promote immobilization, elevation. You can do antibiotics. You can do your topical medications. But if we don't get this treated, it may progress to gangrene, in which case they could lose part of that extremity. If it's bacterial, viral, or fungal, most of that is contagious. Just remember, as the nurse, you have to do your hand hygiene and you have to wear gloves, especially if you're coming into contact with purulent material. All right, you don't want to transfer that from our hands to our face, and then we're going to just keep spreading that infection. Examples of viral skin disorders are herpes, type 1 and type 2. We know that this transmission is direct contact with an open lesion. Type 2 is primarily through sexual contact. Most common, you're going to do a lot of patient teaching, and you're going to put them on antiviral medications such as acyclovir. Right? You're going to have to culture the lesion. So you're going to have to tell that client, if you suspect this, you need to come in when you're having a flare-up. Your goal is to relieve symptoms. Again, teach them about warm compresses, pain control, and obviously teaching techniques to prevent that spread of infection. Herpes varicella. So this is herpes zoster, the shingles. Unfortunately, anybody can get this. There is a shingles vaccination. So if you have anything about promoting vaccination status for this, you can. So the greatest risk are to those clients who are already immunocompromised. It's going to be painful. You're going to have this redness, this rash along your spinal nerve pathways. That's what makes it so painful. You can have vesicles, and just a lot of pain and a lot of patient teaching. You're still going to use antiviral medications and still teach them about washing their hands and preventing the spread of infection. So again, we're going to culture, provide pain relief, acyclovir, warm compresses, vaccination. ultimately, if we don't treat this, it could be fatal, especially, again, if you are immunocompromised already. We are probably all familiar with candidiasis. So, right, this appears in warm, moist areas in the groin and the oral mucosa and the submammary glands. There is no excuse for this. This is totally 100% our fault. If that client is unable to provide hygiene for themselves, we are not doing good oral care. We are not doing things to remove moisture. You know, they have the cheesecloth now that we can cut up and put under them to help wick away moisture from those areas. So just the normal clinical manifestations that you would expect to see, and you can do treatment with like antifungal medications. It's fluconazole. But the big one is hand hygiene and daily hygiene for those patients. Xerosis, which is dryness, and pruritus, like go hand in hand. If your skin's dry, it's going to itch. It can be the first indication of something systemic, but generally speaking, it's just about, again, providing hygiene and hydration to that client. Reinforce and teach self-care. Right, we're going to take measures to control itching. I know we can use Benadryl, but again, that you have the risk there that that's going to make them groggy or sleepy. It's just our goal is to help prevent the itchy and the scratchy, right? So if warm compresses, if it's a lotion, whatever it is, to help them not pick at whichever area it is associated with. Scabies is one, unfortunately, we see in the clinical setting. This is, again, due to poor hygiene. It's going to be transmitted by prolonged contact. You're not going to get scabies just by walking into the room and saying hi to your client. You'll see a wavy brown thread-like lines. You'll see itching, excoriation, and medical interventions are still going to be topical lotions that are medicated. And the big one is probably we want to make sure that we're going to treat all family members because they've been in close contact, right? Wash all linens and clothes in hot water with bleach, and then you're going to make sure that you're wearing gloves when giving care. You wear gloves, we can wear a gown, whatever makes you feel comfortable. Contact dermatitis and urticaria are kind of similar. Contact dermatitis is like poison ivy, poison oak. You know this is going to be over the counter, generally speaking. Topical or oral corticosteroids. Obviously remove the cause. Wash as soon as possible. Cold compresses, wet dressings again. And then you see the use of antihistamines. Urticaria is an allergic phenomenon. And the big thing there, if you see a question about urticaria, is going to be about removal of the triggering agent and hygiene. So if it's a medication, we have to identify which medication. Usually that's from a long history of talking to the client. Again, we can prescribe antihistamines, topical or systemic corticosteroids, something like an atopic dermatitis, which is an eczema. It's usually genetically linked. You're going to have to do patient teaching about long-term interventions and making sure your skin stays hydrated and lubricated, corticosteroids, and that they possibly could go for phototherapy. Psoriasis is an autoimmune chronic dermatitis. You see silvery scaling plaque. Again, it's going to be kind of chronic. There are medications to help control it. Our job is to reduce inflammation, use our topical medications, and UV light can be used to help control the signs and symptoms. Most of it is, again, this is outpatient stuff that you don't see somebody coming into the hospital because they have psoriasis. Those clients that can have phototherapy, it's just patient teaching. It's just ultraviolet light or combinations of UVA or UVB to help treat and control the symptoms. If you do have a malignancy, you can use radiation, you could use laser therapy, but most of it's probably going to be topical medication. We've talked about the use of antibiotics, oral antihistamines, and steroid therapy, wet dressings, some debate on the evidence-based practice of wet dressings and the use of this, but if it makes them feel more comfortable, then that's okay. And then hand washing, safe disposal if it's infection like impetigo, and just making sure you're doing all of the family for those situations. So you may have to teach this client about wet dressings, about soaking, topical medications, control of itching, prevention of the spread of the infection, prevention of secondary infections, like making sure we're recognizing this early. A lot of patient teaching depending on the specific skin care. And of course, there's also the Maslow's or the psychosocial portion of chronic dermatitis. And that's, from my perspective, the big points behind your integumentary system that I would look for on NCLEX.